Hi, and welcome. And thank you for joining our very first Reflux community event. I'm Stephanie Wells from Mike and Steph in the Morning on B104. Now, we've held this event in person in the past, and although things are looking a little bit different this year, our program will be just as informative as it always is. Now, for some general housekeeping rules, I want to let you know that all participants have been muted with their video cameras off upon entry. And this is a way to eliminate feedback and any distractions throughout the program. We greatly encourage you to ask questions this evening. So if you have a question, you can use the chat feature, which you'll find on the right side of your screen. You will select the option to send your questions to all panelists. Again, you're looking for all panelists. And this way, they will be sent only to myself and our physicians this evening to ensure confidentiality from other attendees. You can address your question to a specific doctor if you wish, or you can ask a general question and we'll make sure to direct your question correctly. This program will be recorded and will be made available to watch again at a later time. And finally, when you exit the event at the conclusion of the program, a survey will pop up. So if you can please take just a few minutes to complete, not only is it greatly appreciated, but then we use that information in planning future events. It is now with great pleasure I'd like to introduce our physicians who will be speaking this evening, including Dr. Paul Sasonic with LVPG General Bariatric and Trauma Surgery, and Dr. Hiral Shah with Eastern Pennsylvania Gastroenterology and Liver Specialists PC. Welcome, doctors.
Thank you. All right, well, it's thank you for the introduction, Steph. It's a pleasure to be here. As Steph said, Dr. Sasonic and I work very closely together along with our colleagues in the surgical and the GI group. The plan tonight really is to just provide some informative data and background to the community. What we love most is to, help our friends and family. And I think all of us have had loved ones with issues, I'm sure, of reflux-related kind of disease and surrounding kind of disease processes of this. And so tonight really is just an informal discussion, very informal, but also planned to be informative and to hopefully provide help and resource for folks to help with these issues. Again, we're very proud of this program because it's a multidisciplinary concept with our surgical colleagues, our gastroenterologists, we have motility specialists, and we're going to get into some of these things a little bit with you tonight. And hopefully this format works to provide answers to any questions that we can help with as well. So I'm going to kind of sound redundant, but I'll say next slide with these, and we'll kind of go through our topics here with what is reflux disease, what are the symptoms of GERD or gastroesophageal reflux disease, and how common GERD is. And we're going to split this discussion up between myself and Dr. Sasonic from a gastroenterologist and a surgical kind of a standpoint, and come together with a kind of what we think is useful for folks to kind of approach this process. And we'll go to the anatomy and physiology and treatment, and we'll have time for questions as well. And so with that, we'll kind of keep working our way through this in the new age of web conferencing. So let's start really with what gastroesophageal reflux disease really is. Next slide. And, again, this is a situation that affects all of us. I'm sure all of us have had reflux at some point in some way. The reality is that everyone has reflux. It occurs when contents of the stomach flow back up into the esophagus. This happens in many circumstances in many ways as a valve in the lower esophagus, and it's meant to hold things from coming back up into the esophagus. And when things run back up the wrong direction, folks tend to get these symptoms of reflux, and we're going to talk a little bit about that. And I think this picture is a pretty straightforward visualization of kind of what's going on. Go to the next slide. And then the common things again are, what are the symptoms of reflux and GERD? So heartburn is what we see on TV. It's the commercials we see, it's the chest discomfort, and these are the kind of the classic symptoms that we talk about often. Heartburn is the most common symptom that people will come in with and describe this burning sensation. And it's important to know that it's not cardiac, and those things are obviously very important to rule out. But this sensation of heartburn often is the most common presentation for symptoms. But what people fail or don't always remember is that there's so many other symptoms of reflux. Let me go to the next slide. And there are a variety of reflux, and we've in our groups have all seen patients with a variety of reflux issues, and these are kind of variable and include all types of symptoms of sore throat, for example, because the acid is coming up. And a fancy term for that is laryngopharyngeal reflux, meaning that the acid can almost come up to the throat because it can be so bad. Belching can be a phenomenon associated with reflux. A change in voice, hoarseness, again, those acid symptoms of coming up all the way up that tube into the oropharynx and affecting the oropharynx, where the physicians can even see redness in the throat area with lights. Regurgitation, which tends to be a common scenario and also be a result of reflux that can be a common presentation for folks, and also very much mechanical with regards to the symptom of reflux. Chest pain, again, kind of synonymous with the heartburn symptoms. Again, patients can have these variable symptoms. And cough, there's many patients that present with recurrent cough symptoms and have even had acid reflux to the point where they feel it's going kind of down the wrong tube, so to speak. And patients will have throat clearing with this cough because of the reflux. And asthmatics can often have overlap symptoms of reflux as well. So you could see that it's just not one single symptom. Gas discomfort can sometimes be reflux, and you may go to the dentist, and the dentist may say, "Oh, you're having some enamel wear, and perhaps this is reflux," and they see a sore throat. So these sensations of a globus sensation, which basically is a phenomenon of feeling something stuck in your throat area, could just be a sensation of reflux that's coming up into your throat area or upper esophagus. These things can cause strictures, narrowing, and such. And so, these kinds of things are important to talk and just realize from the community standpoint. We'll go to the next slide. But what happens when we don't treat reflux, or what are the complications of untreated reflux over the time frame, over time and duration that's lengthy? Well, we know that patients can have inflammation. Reflux is essentially like scratching. It's scratching of the esophagus. And if you have that over and over and over, you can get inflammation in there. And that inflammation can lead to narrowing in your esophagus. So sometimes folks can even have difficulty with foods getting down or trouble swallowing because of the narrowing. And that inflammation is important to know about because it needs to be investigated for conditions that can be precancerous, such as Barrett's esophagus, which is something that's talked about in the community and in the GI world and surgical world as well often. But something that I think we can talk about more, but it certainly over and over, inflammation in the esophagus can certainly lead to scarring. And these are things that I think when we talk about reflux in a community setting, we're not just dealing with one particular issue. And as a multidisciplinary group, we're not always just focused on just reflux and that's it. You have reflux, or you don't have reflux, and that's it. That's not kind of how we're approaching it from our standpoint. We're very wanting to be very comprehensive in our approach. And what we're trying to work through is really treatment of all conditions in this kind of world of presentations. So these can include a variety of disease processes, but just for the purposes of this presentation, these things are also on the forefront of our thoughts and our minds with regards to acid reflux in the esophagus. So something to keep in mind is, we're trying to evaluate patients with from every angle, not just a narrow window. Next slide. So again, how common is GERD? And GERD is a very common problem. It's a growing problem. We see it every day from an office standpoint, from the complications of reflux, from issues related to reflux, but it's 20 to 40% of the population suffer from this disease. It's a very common process. Again, I said our family, friends, our loved ones have probably all had times of issues of reflux, and so much of time and energy is devoted to the care and visits, primary care visits for reflux annually. As a gastroenterologist, it is the most common outpatient diagnosis that we see and discuss. So a growing problem for sure, and certainly many opportunities as far as workups and evaluations that are also available. Next slide. So who gets it? Well, again, everybody gets some element of reflux. The reality is this valve is not perfect, and this lower sphincter muscle does always allow some element of reflux in everybody. It's really patients that have symptoms of reflux and persistent chronic issues, or issues that are kind of relentless, or issues that are becoming problematic for the patient, that we need to work together. And patients that are seeking treatment, obviously things are becoming more severe. These are the patients that we need to kind of focus on and try to help. Obviously the asymptomatic patient, the patient that has minimal to no symptoms, we're not obviously worried as much about these folks. We need to discuss it. We may need to talk about it, but it's the persistent reflux issues and the persistent symptoms that we really need to kind of tackle and work towards. These are the folks that I think, we need to kind of address and assure that there's no worsening issues that are ongoing. So we'll go to the next slide. The risk factors are very well known to many patients and the community, but can be missed or forgotten. Central obesity, or especially obesity around the mid portion, certainly has an association with persistent or ongoing risks of reflux. Pregnancy, for many reasons, obviously the weight distribution and pressures physiologically can result in worse reflux. Connective tissue disorders are known to have an association with reflux, and that can overlap often with problems with motility disorders of the esophagus as well. Patients can have conditions where the stomach doesn't move contents out of the stomach well. And with that condition, often referred to as gastroparesis, contents, again, if you remember that picture early on, contents can flow back up into the esophagus. So that can be a risk factor for gastroesophageal reflux. Hiatal hernias, which is an anatomic issue of the muscles that are above and below the diaphragm, and Dr. Sosonic will kind of get into this a little bit more, can be a significant contributor to reflux. And we'll get into that again tonight a little bit. Next slide. Now, what things aggravate reflux? So a lot of folks will say stress this is stress, and stress results in my reflux. And they're not entirely wrong. And they're correct in many ways. It's not necessarily always the stress directly, but when we're stressed, we may drink more alcohol when we're stressed. We may eat more, like stress eating. When we're stressed, we may not sleep as much. And we're eating more before bed. We're eating larger meals, eating fattier foods, smoking cigarettes, and perhaps someone smokes, but perhaps they smoke even more during times of concern or other things. And so these things, without a doubt, are part of the spectrum that contribute to reflux. And they need to be looked at. Lifestyle and how we live and what we eat and drink and our daily habits certainly have consequences in the world of reflux and should be looked at seriously and discussed as well. Next slide. And with that, I'm going to turn it over and give to my colleague, Dr. Paul Sasonic, to kind of get into some of the anatomy and physiology.
All right. Thanks, Dr. Shaw, for beginning the talk and giving us all that information. Again, I'm Paul Sasonic. I'm one of the general and bariatric surgeons here at Lehigh Valley Health Network. And I specialize a lot in the surgical treatment of these foregut issues, reflux and weight loss. So in order to understand reflux and its treatment options, we first have to ask what happens when we eat. And so basically food, we take into our mouth, we chew it up, and then we swallow down the food through our esophagus. And the esophagus slowly pushes that food down with a process called peristalsis. So it contracts, it slowly pushes the food down. It then passes through something called the lower esophageal sphincter and enters the stomach where digestion begins. So that lower esophageal valve is a very important part of this process, and Dr. Shaw alluded to that earlier. It functions as a one-way valve. Its job is to keep the contents that are brought into the stomach to remain in the stomach. And its function is based upon nerves and muscles and the surrounding tissue in that area. If that lower esophageal sphincter becomes out of position, or if those controlling factors aren't present, then we can sometimes get reflux. Beyond the lower esophageal sphincter, we then enter the stomach where the food is slowly digested. The stomach churns the food, it breaks up into smaller pieces, it adds acid and enzymes, and then slowly the food leaves the stomach and goes through the pylorus, which is the gatekeeper of the stomach. So just the basic anatomy of our stomach is that the entry point is called the cardia, the upper part is the fundus, and the fundus is important in our treatment options. So we'll be talking a little bit more about the fundus in a minute. There's the body of the stomach. Not labeled here is the antrum. So this is the part of the stomach where the majority of our acid is produced. And then at the end of the stomach is the pylorus, the gatekeeper, what slowly lets food out to be digested. So you have reflux. I assume that's why the majority of patients are tuning in today. And so the question is, what went wrong? And there could be a variety of factors, but it often involves some issue related to that lower esophageal sphincter, allowing the contents from the stomach to come back up into the esophagus. And it's frequently associated with a hiatal hernia, which has been mentioned. So a hiatal hernia is a displacement of the stomach into the chest. So normally the entire stomach and that lower esophageal sphincter remain in the abdominal cavity. But over time, sometimes the opening can get bigger and the stomach and that lower esophageal sphincter will slide up into the chest. And by moving up into the chest, it displaces that valve and it makes it less functional. There are multiple different types of hiatal hernias. Just to kind of depict what they look like, a normal lower esophageal sphincter would be below the diaphragm. A sliding type of hiatal hernia, which is very commonly associated with reflux disease, is where the junction just slides straight up into the chest. A type 2 paraesophageal hernia is an uncommon type of hernia, but it's where the junction stays down and the stomach sneaks up next to it. And the last type is something that we frequently fix surgically, but is not a significant reflux causer, is a type 3 paraesophageal, where the junction is up above the diaphragm and the stomach is above the diaphragm. So the endoscopic view of a hiatal hernia looks like this. So that basically means we have a camera going through the mouth, looking into the stomach and turned back on itself. So we're looking at the lower esophageal sphincter from the stomach side, and what we can see is the scope, the camera, and we see the hiatus, and this is allowing, again, for the acid contents to go up into that esophagus much easier. So I'll bring up this picture in a little bit after you see one of the treatment options. So with that, the question is can we fix it? And there's a variety of treatment options, and they're not all surgical. So I'm going to turn this back over to Dr. Shaw to begin some of the treatment options.
Yeah, thanks, Paul. So, most of this, with regards to the medical side, when we talk about the preliminary treatments in reflux disease, is lifestyle modification. We talked about that a little bit earlier, and much of this is amenable to lifestyle changes. And we certainly can make changes in our lifestyle to help these issues. And then there's medical management, and we'll talk about. Finally, there's folks that will need to consider anatomic changes and surgical and endoscopic interventions to help from an anatomical standpoint. And we'll go into the next slide and talk about these a little bit. So as we spoke about a little earlier, the hard part with this is we're all human, and we all kind of do some of these things, and we may not get enough sleep. We'll have an extra cup of coffee. We'll sleep late. We'll eat late. Have big meals before we hit the sack. We're all guilty of it. And I think these things can certainly be intervened on. It takes some serious efforts and help often, but these are the initial steps to think about for the treatment. Lifestyle modifications are something we should all kind of be seriously considering and discussing and counseled on to help with some of the early symptoms. Next slide. But for many folks, this is not enough, and it works for many people. However, and in a good majority of folks, despite their lifestyle modifications, they just can't get over that hump of reflux, and kind of quote, they get sick and tired of being sick and tired. They continue to have reflux. It's affecting their lifestyle, affecting their work, affecting their day-to-day kind of environment and quality of life. And these are patients that I think we do need to investigate a little bit more seriously and work towards some treatment goals. Next slide. And we're going to talk a little bit about medical management here. Let's see if this comes through. Next slide. All right, there we are. The options for medical management of reflux are well known to the medical profession and probably many to the community, because we've seen commercials, we've seen and discussed it with family and friends and such, and we've talked about the purple pill with proton pump inhibitors. Folks may have known about Pepcid and Zantac, which Zantac was recently taken off the mainstream markets, and from the top one, the antacids, which we often discuss on a routine daily basis, including Tums and such type of medicines. So these are some of the options, and many of them work quite well and are very good in general. We'll go to the next slide. And so again, just to outline some of these, you may have heard the commercial names, Prilosec, Prevacid, Nexium for the proton pump inhibitors on the right side of the screen, and on the left side, Tums and Alka-Seltz and Mylanta. And in the middle are the medications such as Pepcid, which are called H2 blockers. It's really the last two H2 blockers and the proton pump inhibitors that really block acid production. Next slide. And again, these medicines, specifically the proton pump inhibitors, there's little pumps you can think of in the stomach. And it's literally what these medications are. They're proton pump inhibitors. They block these little acid pumps in the stomach from producing the acid, and that acid's what is resulting in many of the issues of reflux, because the content of acid in the stomach is going up that tube, if you remember that early slide. And oftentimes we can effectively treat patients, many patients. This is one of the most prescribed medications by gastroenterologists and primary care physicians, as well as available in generic and over-the-counter availability in pharmacies and grocery stores and such. So these are effective treatment options. They're used with great success in the right choice in many patients. But this has to be discussed, and we do discuss these things regularly. Next slide, please. But as many folks may be, I can't see every question that's necessarily coming in, and I'm sure folks will ask it. And these are the things that concern a lot of patients, and it concerns all of us as providers as well. Well, what are the long-term safety issues with long-term proton pump inhibitors? And what are the concerns with using this regularly? Next slide. So there's been a lot, and anyone who's probably on this forum will know that there are newspaper articles, CNN blips, and magazine papers and discussions with families and friends and such. And there's so many things in the press that have been brought up over the years with proton pump inhibitors, and they're all there. And some of the things that come up often discussions are dementia, kidney issues, vitamin deficiencies with these, risk of C. diff or Clostridium difficile infections, bone loss, interactions with medications. So there's a variety of concerns that patients have. And as providers, we do realize these. There are publications with these. And I'm going to see if we can touch on this a little bit. Next slide, please. So are PPIs good? They provide significant relief. They're helpful in many patients. They're the right choice for many patients, and many patients do quite well on them. Or are they all bad, or should we be writing these off and saying, oh, these are not good medications for us? Next slide. With those particular issues in mind, expert consensus in the United States and worldwide still states that proton pump inhibitors are a benefit to patients that have persistent reflux and have ongoing symptoms. They are overall, by expert consensus, still a medication that can and should be prescribed in the appropriate patients. The majority of the studies that have been reported have been associative data, meaning that there's always a risk with proton pump inhibitor, but they're not necessarily causative. They're associated with these conditions. That doesn't mean that that they're not causing or related to these medications. There's certainly publications related to it. And in my opinion, it's not necessarily just one issue. So focus on dementia, focus on the renal issue, or focus on one thing, but it's the cumulative issues that I think patients are now thinking more seriously about, and I think having the discussion about other options. To this date, still, proton pump inhibitors do provide significant relief and can be a very, very good medication in addressing the reflux symptoms. However, what they cannot do is fix the anatomical issues or mechanical issues. Medication will not fix that portion of the process. And it comes back to some of the symptomology. The regurgitation, for example, can often be difficult to fix with medications. That's a mechanical issue in many situations. But a trial of these medications often prove to be successful in folks as well, and should be on the table as a treatment option. Next slide. And then we're going to get into some of the mechanical issues and turn it back to Dr. Sassani.
All right, so I'm going to go over the procedures that we can use to restore anatomy and stop some of those regurgitation symptoms. So when we talk about the mechanical things, we're talking about restoring that LES function, and this can effectively treat the mechanical symptoms, and for a lot of patients, get them off the medication treatment of their reflux disease. The main types of procedures that we can perform would be what's called a laparoscopic fundoplication, a transoral incisionless fundoplication, or a TIF for short, and then something called magnetic sphincter augmentation. So I'm going to go through each of these and describe each. So the fundoplication is a type or a surgical way of treating the mechanical symptoms of reflux that has been around for a very long time. It is, has been considered the gold standard in surgical reflux treatment. And with this procedure, it's performed laparoscopically, which means we make several little tiny incisions on the abdominal wall. We place some air into the abdomen in order to work safely, and we're able to do these procedures through those small incisions in a relatively short period of time. And the advantage of the small incisions is just that they result in less pain, quicker recovery, less risk of infections or hernias. So by doing a fundoplication, we can treat a hiatal hernia if there's one present, and then we can strengthen that lower esophageal sphincter. And we do that by using that fundus. So that fundus was the upper part of the stomach. We basically pull it behind the esophagus, and then we sew it back together, creating an area of tightness on that lower esophageal sphincter, or adding some pressure to that point. It does give good symptom relief for our patients, but one of the problems of a fundoplication is that it can trap air and make patients feel bloated. They may have some difficulty with belching or vomiting. Some of the two of the other procedures that we can offer are procedures that involve not using that fundus, and that one is the magnetic sphincter augmentation, something called a LINX procedure, and then the TIF. So getting back to that picture from before, we want that junction to be down below the stomach, below the diaphragm, and then we can go ahead and somehow augment that pressure. And so when we talk about the LINX, or the magnetic sphincter augmentation, we're talking about a medical device and not the animal LINX. It is a band of multiple beads of magnets, and it is slipped around the esophagus, and it creates a very precise location for extra pressure on that lower esophageal sphincter. Again, it's performed laparoscopically or with cameras, and it allows patients to more easily belch or to vomit if they need to. And we do see that patients can go home the same day because not manipulating the fundus does result in less initial discomfort for our patients. It does result in a very high patient satisfaction. So the way it works is basically if you have reflux here and acid's coming back up the esophagus, we can simply apply the LINX to that lower esophageal sphincter region, and it creates enough pressure to stop acid from coming back up. But these are not very strong magnets. In fact, if you have an opportunity to come to the office, we have a sample one that you can see, and you'll see that it doesn't have much strength to it at all, but it's just enough to stop the acid, but not enough to stop food going through that lower esophageal sphincter and into the stomach. So if you remember this picture from earlier where we looked at a hiatal hernia from the stomach side, where you can see the space around the endoscope, this is after the hiatal hernia has been fixed, and now you can kind of make out the indentation of the LINX device that is around the scope. So it creates that tightness around the scope and makes it hard for acid to go back into the esophagus and create those symptoms. The transoral incisionless fundoplication is another procedure that we commonly perform here in conjunction with GI colleagues. The TIF procedure is an endoscopic procedure. So this is a procedure that we perform actually through the mouth, and it can be performed without the need for abdominal surgery, although a large majority of our patients do have an associated hiatal hernia. So sometimes they've been told before that it's just a small or insignificant hiatal hernia, but it becomes really important to address that hiatal hernia when you're talking about mechanically stopping reflux. and regurgitation. And so we will frequently combine the use of this endoscopic technique with the surgical repair of the hiatal hernia. It still allows for non-use or sparing of the fundus, and patients can go home if they feel up to it at the end of the procedure. So this is the actual device that creates the TIF, or the fundoplication. And basically what it does is it comes down the esophagus, goes into the stomach, and we create a valve or a flap at that upper part of the stomach, and it will effectively prevent acid from refluxing back up. And this is actual pictures. So first you're seeing the hiatal hernia around the endoscope. Here is a procedure picture taken during the procedure, where you see some blood from the actual procedure. It does, we are passing little pledgets through. And then this is what it looks like 5 years later, where it's still holding tight against the esophagus, against the scope, and it would make it hard for acid to go back up. So when you talk about these procedures, there's a scale that how we treat patients. On the low end of your reflux disease, we want to treat you with lifestyle modifications. Then we add in those pharmaceuticals that Dr. Shaw was talking about, and then as we progress on, we get into some of the other procedures. And we have both the TIF and the LINX are good procedures for patients kind of in that mid-range, but then as hernias get really big, some of our hernias that we deal with are the entire stomach, and then some other structures that go into the chest. That's when we go back to more of the conventional surgical treatments. Just some more details on who a candidate for a TIF is. In our program, it's a patient greater than 18 years of age and having significant symptoms, as well as a disruption of that valve in order to get adequate treatments. We generally want the hiatal hernia component to be relatively small. Again, this is on a scale of how significant your underlying anatomic issues are. And we want to see that you truly have evidence of reflux before we would do one of these procedures. Patients who may not be a candidate for a TIF or a LINX or the hiatal hernia are, at least for the TIF and LINX, are a hiatal hernia that's too large. We can do larger than 2 centimeters with these procedures, but it is stuff that we consider. Paraesophageal hernias are a little bit different, and sometimes have to be treated differently. BMI, which is something called your body mass index. I'm going to speak a little bit more about that in a minute, but basically as your weight gets to be higher, it becomes harder to treat reflux with these type of procedures, and there's actually a better procedure that we generally recommend. If you have significant changes in your esophagus related to other diseases such as cirrhosis and varices, other motility issues within the esophagus. So there's a lot of things that we're looking for. We're doing a workup. We're finding what is the best thing that we can do for you and making sure that we don't create problems. And so we're always paying attention to things that would not apply to our patients. I'm not going to bore you with data slides, so this is really the only one in the whole presentation. It's just a study, and what this shows is that patients before intervention had a high HRQL score, which is sees how significant reflux is in your daily life. So you saw a significant improvement in all studies, pre-LINX versus post-LINX, and you see similar results with the TIF and the fundoplication. So we mentioned that weight may be a factor. If your body mass index is high, greater than 35, and especially if it's greater than 40, then possibly considering a different procedure would be better. So your body mass index, in case you have never heard of it, is a ratio of your height and your weight. So basically, you look at what your height is, you factor out what your weight is, and it will give you a number of where you are. So patients, as you get into this yellow and pink area, they become patients who may benefit rather from our current interventions that we've been talking about tonight. They may benefit more from metabolic surgery. And with that procedure, we're completely separating the esophagus from the acid part of the stomach. So if a person goes through gastric bypass surgery, they generally will have complete resolution of the reflux immediately with the surgery, and then they would get the added benefit of improvement of their weight. So there is a bariatric program here that we would encourage you to consider enrolling in if your BMI fits into that higher category. So, the question is what you're feeling, is it GERD? And so we want to work that up and figure out where you are. So the first thing you get when you come to our office is basically a little survey to fill out looking at what your symptoms are and how much it impacts your life. So that's the first step. And then we move on and do a series of tests that would help us to really define what your anatomy is, what kind of changes have happened because of reflux, and then we look at other things that will impact the treatment options that we give you. So patients frequently will get an endoscopy or a camera looking into the esophagus and stomach. A lot of patients will get pH testing. So if in order to prove that you're truly having reflux, we want to actually measure the amount of acid that's coming up. So if you don't have objective signs of reflux that we can document, then frequently pH testing or acid testing would be performed. When we're considering our interventions, a lot of patients will need to undergo a manometry study, and that's looking at how well that esophagus works. So if we go and apply a change to that lower esophageal sphincter, but your esophagus doesn't work well, then that's going to create more problems than the reflux you had. So we're very cautious about making sure that we don't create issues, that we want to make things better. And as part of all of this, we add in other X-ray studies, such as a barium esophagram and other diagnostic tests to help with identifying your disease process and treatment options. So almost there. So tonight we went through the what is reflux, the symptoms of reflux, how common, talked a little bit about the anatomy, and went over the treatment options, relatively quickly, so we don't hopefully bore you too much. Just how do we do the workup for your reflux? So we have a treatment program here. It was really built as a collaboration between Lehigh Valley Health Network, LVPG, with EPGI, which Dr. Shaw is a part of. And it's really a multidisciplinary team of gastroenterologists, surgeons, and other clinicians who come together and try to create the best results for our patients and give them a comprehensive evaluation and treatment plan. And it's really individualized to each person because we're all unique. We all have little factors that may change the treatment algorithm. So we're always, we sit down with each person and figure out what works best for them. We do offer all the current options as far as TIF and links in the standard fund applications. We have a navigator, or we have navigators that will help with assisting patients through the process of getting the test done and getting their follow-up. And then we have long-term follow-up of our patients through our office and the gastroenterology office to continue treating reflux, because its reality is it's a lifelong problem for a lot of patients. So in the program, there's multiple physicians. These are just the more the procedure-based doctors. Myself and Dr. Shaw are listed here. There's also another Dr. Shaw in the group. Dr. Beeman is my partner here at the Cedar Crest site, and Dr. Garcia is at the Muhlenberg campus. And there's contact information here, but at the end of this presentation, there'll be a survey that asks for your opinions, and then we're gonna ask some basic questions. And one of them is gonna be if you want us to reach out to you to look into some of your treatment options. So please take the time to look over that survey at the end. And I guess with that, I will turn it back over to Steph to see if you have any questions.
Indeed, thank you so much. I don't know if I had to switch computers here. I apologize for the technical difficulties, but thank you again, Dr. Sasanik and Dr. Shaw, for the valuable information that you've shared this evening. And we, of course, are opening it now to our question and answer portion of the evening. And we're going to try to answer any and all questions that do come in regarding acid reflux. Now, I had mentioned earlier that you want to use the chat box on the right-hand side of your screen to ask a question to all panelists. So make sure you're selecting all panelists, and we will do our best to answer as many of those questions as possible. And doctors, I have gotten quite a few questions already. I'm going to kind of go down the line, and I might need your help with quite a few of these. One is example coming in asking, can Barrett's or Barrett's go away? Am I pronouncing that correctly?
Yeah, that's Barrett's, and Barrett's is common. first off, we'll say that we see Barrett's a lot, and people get nervous about Barrett's. There's a lot of folks that get concerned. What I think people need to understand is that Barrett's is precancerous, but the risk of Barrett's is evolving into a cancer is very small. It's about 0.5%, or 1 out of 200 that can evolve into anything sinister like esophageal cancer. So the risk is small. How do we treat people with Barrett's? It is the national and worldwide standard to put patients on proton pump inhibitors. That's to reduce acid. By reducing acid, you're reducing your risk to progress any Barrett's. And with that medicine, patients' Barrett's can sometimes kind of regress, and it can not necessarily, I don't want to say go away, but it can regress. It can also come back. And so the standard of care for patients with Barrett's is to have routine endoscopies every 3 years. The guidelines suggest every 3 years to evaluate the mucosa, biopsy, but to remain on this medicine to reduce the risk of developing any esophageal adenocarcinoma or esophageal cancer.
This question is coming in from Diane. Is lansoprazole a PPI or a blocker?
Yeah, that's a PPI. It's a proton pump inhibitor. Yeah.
Okay.
Otherwise known as Prevacid in the kind of commercial name.
Gotcha. History of gastric bypass has episodes of 10 minutes or more of belching just air. Is this normal?
I guess I'll take this question since I also do the gastric bypass surgeries. There's a lot of changes that occur afterwards with the digestive process after a gastric bypass. It can be a normal function afterwards, but we generally would want to explore that a little further just before we'd say don't worry about it. So most patients that come in complain of problems with intake and the material coming back up, or even if it's just gas, we would routinely just do a quick endoscopy, look in the stomach, look at the anatomy that was that they have now after the surgery, and see if there is any particular problem. Though if they're not having significant regurgitation or reflux, then generally doesn't require treatment. But you just want to make sure.
Okay. This one is asked the question, how long is too long to be on PPI medications?
Yeah, it's a great question. The goal and the current standard of care really is to reduce your proton pump inhibitor to the lowest dose possible. The reality is that patients do sometimes need these medicines, and the data it's hard to relay data to the public sometimes because it's associations. So associations are sometimes difficult because they're not always responsible for the problem. So if someone takes a proton pump inhibitor every day, let's say, and also let's say drives every day and gets a ticket when they drive. Now, proton pump inhibitors are associated with getting a ticket in the car. So did the proton pump inhibitor result in the ticket? It's an association. So these kinds of things in research are tricky to kind of pull out. And the trouble with a lot of the data is that all we know now in the news or when we read about these things are sometimes, well, proton pump inhibitors result in tickets. But when you look at the data and you have to kind of scrutinize things, they're not always so clear cut. There are things we do know, and I think the mounting data with so many different things having associations. So there's been association with kidney issues, dementia issues, with C. diff infections, with pneumonias, and so there's certainly associations that can be concerning for patients. I think these deserve conversations and uh, discussions. But that being said, you want to try to be on the lowest dose possible, and you should try, if you can, with your provider, to step down into the H2 blockers over time, if you can tolerate it, and try to reduce those medicines. And some patients can't, and that's okay. It's just something that we should try to do, is to use the lowest dose possible.
We actually have two questions about hiatal hernias. Is it possible for a 15-year-old to get one? And also, can a hiatal hernia grow over time?
So hiatal hernias certainly can occur at any age, and you do see them in children and adolescents. They are treated surgically by the pediatric surgeons here at the hospital. So if there was a significant hiatal hernia and reflux, and they're of age less than 18, then I certainly would recommend being seen by one of the pediatric surgeons. So hiatal hernias, they start, generally they do grow. They start out small, and then over time, the constant pressure in the abdomen of lifting or coughing or just doing normal activities slowly kind of pushes that stomach further and further up into the chest. So what starts out as just a small little tiny hiatal hernia sometimes turns into the entire stomach in the chest. So over time, they do tend to grow.
This question actually may have just been answered, but I'm going to ask again. Are there greater risks for taking PPIs while also undergoing chemotherapy treatment?
That there can be associations again with chemotherapy, but generally speaking, these medications can often protect your stomach from some of the toxicities of chemotherapy and medications, even such as Motrins, ibuprofens, leaves. These types of medicines can harm your stomach, and so oftentimes these medications, especially if used around the times of treatments and things, can actually benefit and protect the lining of the stomach and the esophagus.
This coming in from Marlene. I've read that melatonin may be effective at reducing heartburn and GERD symptoms. Your thoughts?
Melatonin for heartburn, and what's the other one?
GERD symptoms.
GERD symptoms. I would have to do some digging for that particular paper and look for that. That is not a kind of a well-known phenomenon, but certainly it might be in some papers. We'd have to kind of take a deeper dive into that. Certainly not mainstream.
Okay. I'm kind of jumping around here a little bit. Kathy asks, is heaviness in the chest a symptom? I don't have burning, but a heaviness that makes it difficult to take a deep breath.
So, I think if Paul, you would agree, as a comprehensive group, we need to be aware of everything. We're dealing with these issues of reflux, but I think first and foremost, these types of concerns, they should be discussed and evaluated with your doctors and possibly a heart doctor first. I think those things are quite important to make sure that we're not, oftentimes in our reflux world, what we don't want to be doing is thinking someone has reflux when they have a heart problem. And I think that the heart issues need to be investigated first and foremost. That is the priority. So if in fact the heart workup is normal, absolutely. The heaviness, the persistent chest discomfort, heartburn symptoms, they can pretend that they're cardiac, but if the cardiac stuff's negative, then we can go down the path of reflux.
Yeah, and I concur. The idea being that there's a lot of issues that go on in that esophagus and upper stomach region, and we don't know really what's going on until we do some of these tests and really evaluate it. So if you're concerned, this is where we want you to come in, and we can do some simple tests. Some are more involved, some are less, and the idea is get you a straightforward answer and get you on the right treatment path. And well, frequently, it's not an intervention like the ones we discussed tonight.
We have time for just a couple more questions. This one coming in from Michelle. What is involved in manometry testing? Did I pronounce that correctly?
Yeah. Those questions are great. Again, what we want to do is do the right things for patients and help our community. These tests, manometry and also pH probes, are often part of the workup in reflux. So pH measures the acid, as Dr. Sasanik was talking about earlier with a probe. A manometry test is something that patients have to be aware of and know about. And it's not the most fun test, but it's short, generally speaking, and it's a catheter that gets placed into the esophagus or the swallowing tube, and it's done by our nurses in our hospital setting. And it's placed into the esophagus through the nose, and the patients are evaluated, and it's a very important test because what it's doing is it's evaluating the pressures in the esophagus. There are conditions that can, again, not be all reflux, but actually be related to problems of the muscles not moving correctly or squeezing properly. And those are issues that we need to also kind of at least evaluate and look at and know about, because in those situations, the treatment for reflux, for hiatal hernia repairs or fund applications, whether it be TIF or LINX or otherwise, may not be the best option. And so those things are important to know about. But it does entail a catheter. It's not the most fun test. I don't try to lie about it to patients, but it's a very important test to have.
What options exist for someone who has hiatal hernia and low esophageal mobility?
So this can be a little bit more tricky as far as treatment options. We want to fixing the hiatal hernia is a relatively easy part of that, but the question then becomes is what treatment option as far as improving that lower esophageal sphincter function will not add to the dysfunction of the esophagus. And so typically you would throw out the more aggressive pressure causing procedures such as the LINX and the Nissen fundoplication, but sometimes those patients still have enough motility to do the TIF or to do another type of fundoplication, or sometimes do no fundoplication, so just fix the hiatal hernia. And that really comes down to, again, doing that workup. And then frequently that kind of person would be discussed as a panel where we get together usually once a month and discuss patients that we don't have straightforward answers to, and get an opinion from rather than just one or two of us, but rather from the larger group. So that's how that would kind of be handled and looked at more thoroughly.
I have a generic diet question and something a little bit more specific, and I think we'll end with these two questions. The generic, more general question is, what diet can you follow with GERD? And you may have addressed that already a little bit. And also the more specific one, can Globus sensation be corrected by a change in diet from high acid foods like tomatoes, coffee, and spicy foods to perhaps something that's a little bit more bland?
So the diet question is good, and it should be individualized for the patient. I think certainly there's a couple things that we talked about. It's not only all diet, it's also thinking about how much and what times and such. So a lot of times patients will eat at midnight, but they go to bed 10 minutes later, and these types of lifestyle things. So it's a comprehensive thing as far as altering your diet. Yes, spicy foods, acidic foods tend to cause more problems. Citrus foods and acid type of foods such as tomatoes, etc., can often chocolates. These types of foods can exacerbate the reflux symptoms. But something to keep in mind is not just saying I'm going to exclude all that, but also what times do we eat? What do we do? Do we walk maybe after we eat, or do we lay down on the sofa right after we eat? Do we, eat late, and timing of meals, and also quantity? Do we eat small, frequent meals more, or one large meal? These types of things are all kind of playing into the treatment and can be individualized. So something to think about. I think everybody's different for sure. Some foods trigger reflux, but it should be looked at and kind of probably tailored to the patient. Certain foods trigger symptoms in patients more. And the other question I think was, tell me that one again. Sorry.
About the globus sensation being corrected in the change of diet from more high acidic foods to perhaps something that's a little bit more of a bland palate?
I'll take that with regards to the first and foremost, this globus sensation, probably should be investigated first, to make sure there's no mechanical issues. A globus sensation can sometimes be issues of blockages. It should be maybe looked at with x-rays, and sometimes x-rays with contrast to make sure there's no anatomical problems, and endoscopy often, to make sure there's nothing problematic in mechanical inside the tube itself, the esophagus, I should say. But outside of that, dietary modifications are perfectly fine to try. But these kinds of things are probably worth kind of being looked at, evaluated, and investigated. Maybe trial of medications, evaluated with imaging, endoscopy, and kind of made sure that there's nothing else going on. But if everything else has been worked up, then certainly trying those diet modifications are worth considering.
Well, I want to thank everyone for giving such great questions. We got to as many as we could. Thank you once again to Dr. Sasonic with LVPG General Bariatric and Trauma Surgery, as well as Dr. Shaw with Eastern Pennsylvania Gastroenterology and Liver Specialist PC. We really appreciate your time and your insight on everything that was discussed tonight. And this, of course, is our first annual virtual reflux event. This is being recorded and will be made available on lvhn.org in the next few days. At the closing of tonight's event, there will be a small, short survey that'll pop up on your screen when you exit the program. If you have an opportunity to fill that out, again, we greatly appreciate your input, and we certainly use it for any future planning of events such as this. And also, in case you didn't already know, everyone will be receiving a small gift as a thank you for attending tonight's program. And just while you have your calendars out and can plan for the future, coming up on March 30th at 6 p.m., there will be a colorectal event. You can find out more by going to lvhn.org/colon events. And you can also go to lvhn.org/weight loss to find out about the series of events that are held throughout the year. Thank you once again. I'm Stephanie Wells from Mike and Steph in the Morning on B104. Have yourself a good night.
Thank you.
All right, thanks everyone. Good night.
Good night.